Hello, my friends and my colleagues and my fans everywhere. This is Professor Dr. Tarek Ali. This is my third presentation today about medical causes of acute chest pain or acute chest pain of non-traumatic origin in clinical practice. I already talked about the cardiac causes of acute chest pain, which is the most important, most serious, and most life-threatening, most common causes of acute chest pain in clinical practice. And I talked about the non-cardiac pulmonary causes, that is issues related to the cardiopulmonary circuit other than the cardiac, pathology arising in the lungs and in the pulmonary vasculature and in the pleura as causes of acute chest pain. This is finished. Now I will talk about the non-cardiac causes or non-cardiopulmonary causes or other diseases causing acute chest pain, and they are not of cardiac nor of pulmonary origin. What are these diseases? These include the following: diseases of the digestive system, namely the esophagus, and diseases of the chest wall. And these include diseases of the chest wall muscles and diseases of the bones and the cartilages and diseases in the skin. As regards the diseases of the digestive system, let us talk about the esophagus. Esophagus is an important origin of chest pain in some cases in clinical practice. Among the commonest esophageal disease causing acute chest pain is reflux esophagitis related to acid reflux disease from the stomach. And here the acute chest pain will be or will start rather in the lower part of the chest and will be rather central and may radiate up the chest and usually is burning in nature due to the reflux of acid into the esophagus and the irritation of the esophageal mucosa. So it is burning chest pain, which might be diffuse and which might spread up the chest, associated with maybe vomiting with acid reflux and acid regurgitation and the sense of acid in the throat even, and maybe associated also with gastritis and epigastric pain. So it is association of chest pain with epigastric pain in patients with acid reflux and reflux esophagitis. So reflux esophagitis is a recognizable cause of acute chest pain of esophageal origin. Other causes related to the esophagus are what we call diffuse esophageal spasm and esophageal spasm. Diffuse esophageal spasm is a problem in the esophageal motility related to the neuromuscular part of the esophagus. It's not related to the lumen of the esophagus, it's to the wall of the esophagus. It is an esophageal motility disorder, which might be related to local factors in the wall of the pancreas or to systemic diseases. Sometimes it's associated, for example, with systemic sclerosis. We find it is systemic sclerosis in patients with myasthenia, some patients with myasthenia gravis, and may be related to, especially patients with diffuse esophageal spasm, to exaggerated impulses from the brain to the nerve endings in the esophagus, which cause this spasm, which may be partial or total spasm depending on the severity of the condition. So it is a neuromuscular disorder affecting the esophageal motility, which might be due to a local problem in the wall of the esophagus or to more systemic or neurological systemic disease, or to a neurological cause. Diffuse esophageal, although it is, as I mentioned, unknown and with different possible underlying mechanisms, as I mentioned, it's not considered a medical emergency and not life-threatening at all. And usually it presents with chest pain, and also dysphagia is common to both liquids and solids, but more to liquids, and maybe to specific materials on swallowing of specific substances, some liquids or semi-solids. So dysphagia with chest pain, they are characteristic of esophageal spasm, especially diffuse esophageal spasm. Also, this might be associated with vomiting, this might be associated with regurgitation of food and liquid up the chest into the throat. So regurgitation of food and fluid, vomiting, dysphagia, and chest pain are the classic features of diffuse esophageal spasm if it is the cause of acute chest pain. Also, diffuse esophageal spasm may be related sometimes to local factors like infections, especially mycotic infections, esophageal candidiasis, etc. Although this can be more considered among the diffuse esophagitis rather than diffuse esophageal spasm. But if the infection in the esophagus is complicated by neuromuscular affection, it might affect the motility also and cause partial or diffuse esophageal spasm, especially in mycotic infections of the esophagus, and or also sometimes in viral esophagitis. Let me now talk about another important cause, esophageal cause of acute chest pain. After I talked about reflux esophagitis, diffuse esophagitis, diffuse esophageal spasm, the number 4 cause esophageal is what we call esophageal rupture or esophageal laceration. Esophageal rupture is in fact a medical emergency. It might be life-threatening condition, so that's why we should take it and consider it as a medical emergency, and we should pay urgent attention to it, and we should think about it. What are the causes of esophageal rupture? This might be related to use of a medical procedure, for example, during unwise or a hectic endoscopy, which is not done by experienced endoscopist. So although the more flexible instruments available now, they made this possibility of esophageal laceration rupture rather rare in clinical practice to be iatrogenic or due to the use of medical procedure. So the use of medical procedure also might be related to a foreign body. It might be related which penetrated the esophagus, especially swallowed objects, especially sharp swallowed objects, if it penetrated the wall of the esophagus. Also, it might be related to a tumor in ulcerating malignancy of the esophagus. It might perforate into the mediastinum, and here is the problem, that the perforation or rupture will make fluids and the food enter the mediastinum and of course cause mediastinitis and will be life-threatening, and this is a medical emergency because it threatens the life of the patient. It is a medical emergency, life-threatening condition. So perforation of the esophagus is another serious, although rare cause of acute chest pain. It usually presents with esophageal chest pain, that's chest pain of esophageal origin, associated with abdominal pain. So the presence of acute and chest and acute abdominal pain should immediately direct the attention of the clinician to the possibility of esophageal rupture, especially if it's associated with hypotension, with vomiting and hematemesis and fever. So the presence of chest pain, abdominal pain, vomiting and vomiting of blood, that is hematemesis, and hypotension and fever, these all point to the strong possibility of esophageal rupture or esophageal perforation as a cause of acute chest pain. It's considered as a medical and surgical cause at the same time and need attention of both the physician and the surgeon. Acute chest pain due to esophageal perforation or rupture. Consider it in acute chest pain and acute abdominal pain with hypotension, plus or minus fever. This is very important, and vomiting, of course, as I mentioned, and hematemesis but it's not necessary that the 5 manifestations will be present together. Sometimes they present incompletely or rather partial manifestations with a few, but not all the classic 5 features which I mentioned: that chest pain, abdominal pain, vomiting, hematemesis, and hypotension and fever. These are the digestive causes of acute chest pain related to the esophagus. Then we come to the muscular causes and musculoskeletal. The commonest is tight syndrome. Tight syndrome, it is costochondritis related to inflammation of the costochondral junctions, usually evolving in the upper ribs, at the junction of the ribs with the sternum And involvement of the costocondylar by inflammation will cause pain and swelling of the costochondral junctions in the upper chest. And this is, in most of the cases, not known, but might be post-viral, might be related to repeated minor traumas to the chest. It is an inflammatory process, but its exact triggering factor not known exactly. But the ultimate pathology is inflammation and with swelling affecting the costochondral junctions, the junction between the ribs, especially the upper ribs, anteriorly with the sternum, the central chest bone. This tight syndrome will present with chest pain. It's considered in any patient presenting with acute chest pain of musculoskeletal origin. Tight syndrome usually respond to analgesics, sometimes to steroids, sometimes to needs short courses of oral steroids or injections of steroids after trials with simple analgesics, that is paracetamol, and or of course non-steroidal anti-inflammatory drugs like ibuprofen or like Voltaren or that's diclofenac or ibuprofen or naproxen. They can all be used to suppress inflammation and pain in such patients with tight syndrome. And the X-ray is not diagnostic in these patients, and it's diagnosed rather clinically because there is no positive findings in chest X-ray or planar radiography of the chest in these patients in the ribs or in the sternum. It is diagnosed from the history and the physical examination. Tight syndrome, costochondritis. Then we move to other chest wall causes, any muscular strain in the chest related to excess physical activity or to exposure to abnormal air currents or physical environmental factors from the environment can cause also chest pain of muscular origin. And it is usually, pain is usually lateral pain, not central, and more with chest wall movements or with straining and cuffing, the chest pain increases. And it gradually decreases in intensity and in severity. This is chest wall of muscular origin. But don't forget the tight syndrome. This is very important. Also, pleurodenia might be another cause. This is post-viral, related to viral infection. That's pleurodenia presents with pain of chest wall and of pleural origin at the same time related to a certain type of viruses. We call it epidemic pleurodenia. And then we come to other rarer causes related to the skin, which is herpes. Herpes zoster can present with chest pain. And this is related, of course, it is a neurological disease due to affection of the nerve roots or spinal nerve roots by herpes zoster, which starts in the back and then radiates with rather radicular pain. And here it will take a radicular distribution because it is among the nerve endings and the nerve branches, those supplying the chest. So the pain of herpetic neuralgia will be affecting the chest, and it might start in the back and then radiate to the anterior chest in some circumferential pattern. It is rather radicular pain in distribution, and it is more tingling or burning in nature. So the character of pain can help in the diagnosis and point to the possible underlying source of the pain. Here, for example, in pain of neural origin, in herpetic neuralgia of the chest, causing chest pain and acute chest pain, or in some cases subacute chest pain or chronic recurrent chest pain as a post-neuralgic feature, is usually burning in character or tingling in character and associated sometimes with dermatomes of hyposthesia in the if we do sensory testing in the for the skin in the lower chest. So the dermatomal distribution and the burning character or the tingling character, they help to differentiate the pain of neurogenic origin in patients with herpetic neuralgia from other causes of chest pain. So this is all this scope of medical causes of chest pain. I talked about cardiac, I talked about pulmonary, I talked about digestive esophageal causes, I talked about musculoskeletal causes, I talked about neurological causes as exemplified by herpetic neuralgia. This is, of course, an overall description of medical causes of acute chest pain in clinical practice. Thank you so much, and wait for me for other presentations.